This episode was powered by Paul Hodge, a financial planner who works specifically with medical professionals. He has helped members of the BrainWaves podcast grow their wealth and manage risk. Learn more about how to secure your financial future at paul-hodge.com.
You ready to do this?
Mm-hmm.
Okay. You got your notes?
Yeah.
Your questions? Okay. I'm just going to start. As you know, the most common reason for an intracerebral hemorrhage is head trauma. One day, your patient's walking around, minding his own business, and then boom. They're struck by a car. Typically, this type of ICH involves multiple intracranial compartments, subarachnoid, subdural, and intraparenchymal. But for the purpose of this episode, we'll talk about ICH. We're only going to be talking about the non-traumatic etiologies. After trauma, the next most common cause of ICH is hypertension, the silent killer. The blood pressure may remain elevated for years or even decades, not producing any symptoms until it's too late. Then, boom, enters cerebral hemorrhage, or stroke, or myocardial infarction, or whatever else. And 80 to 90% of all non-traumatic cases of ICH can be traced back to hypertensive disease. But what of this other neglected 10 to 20%? In this episode of BrainWaves, I'll be talking about these other atypical causes of ICH with Dr. Steve Messe, Associate Professor of Neurology, Fellow of the American Heart Association and the Academy of Neurology, and author of the 2010 AHA Guidelines for the Management of ICH. Welcome to the show, Dr. Messe.
Thanks, Jim. I really appreciate the invitation. I'm a big fan, and I do appreciate the opportunity to be here and talk to you about it.
So let's get started. As far as etiologies of ICH are concerned, it's probably easy for us to start with the clinical information you get as the neurologist and then move forward from there. When you get a one-liner of a typical 50-year-old male with acute unilateral weakness and a hyperdense intraparenchymal signal on head CT, what features clue you into the possibility that this might be an atypical case?
So anytime there's intracerebral hemorrhage, you're going to want to get a history pretty quickly about whether there's use of antithrombotic drugs, if you can get a history, known coagulopathy, liver disease, or perhaps being on chemotherapy. Certainly any known cancers, that's hugely important. Other conditions, pregnancy, for example, would be hugely important. That might point you down a direction other than just primary ICH. And then radiographic clues, of course, there are many that this is not typical. Part of it is location. That's critically important. And depending on the age of the patient, if you think this is going to be likely to be due to hypertensive bleeds, it's going to be in the distribution in the deep perforators. But if you have a patient who's young and not hypertensive and there's a lobar hemorrhage, that immediately sends up red flags for me. And other things radiographically, maybe a fluid level would be suggestive that there is a coagulopathy.
I'm definitely realizing now in hindsight how much of a loaded question that first one was.
There was a lot there. I barely dipped my toe in.
We'll keep going and then we'll get to some of the more nuanced features of ICH next. So let's say the one-liner was modified to be a 50-year-old male with severe headache and an acute unilateral weakness, same looking ICH on the head CT. How does a headache change your differential diagnosis?
I mean, honestly, the vast majority of patients who present with hemorrhage, if they're awake and conversant, or even not conversant, they're going to be complaining of headache. So that doesn't inherently change it unless we can get the history of whether this was a sudden thunderclap headache. Maybe would be suggestive that there's an aneurysmal component. Again, you should see subarachnoid hemorrhage, not just intraparenchymal blood. And some aneurysms do lead to what looks like primary intraparenchymal hemorrhage, ACOM aneurysms in particular. I've seen do that. But then the other thing I think is more interesting for headache would be the duration of headache. So if this is a patient who had a headache for a week and it's been progressive, and now they're having some neurologic symptoms like weakness, that makes me think of something like a vein thrombosis. So that duration and progression of headache is key.
Let's say the patient were older next.
Amyloid angiopathy would be the condition I would think of for a lobar hemorrhage in an older patient.
At this point, Dr. Messe talks about cerebral amyloid angiopathy as a largely sporadic disease that preferentially affects the elderly. Data from the Harvard Brain Tissue Research Center has identified a prevalence of 2% in patients 65 to 74 years of age, 8% from ages 75 to 84, and over 12% in patients 85 or older. While amyloid beta buildup in the small arteries is thought to be the predominant mechanism for CAA, amyloid beta plaque formation in brain tissue is responsible for the pathology of Alzheimer's disease, although the two frequently co-occur in many elderly patients. Because CAA preferentially affects the small arteries of the meninges and cortex, singular or multifocal lobar hemorrhages are often the observed findings on head CT.
Other things, of course, I think across the age spectrum, consider whether this could be hemorrhagic conversion of acute ischemia. And certainly you want to think about that if there's any signs or concern for endocarditis, but any ischemic stroke can do that. Again, I mentioned vein thrombosis, metastasis of a cancer with hemorrhage. If you take any patient, the ones that are most likely to appear as a hemorrhagic met are the cancers that are just most prevalent in society. So I think it still remains lung and probably colon and breast for women. But among cancers that are more likely to bleed, if you have cancer, of course, it's going to be the classic melanomas and the thyroid cancers and the renal cell and the choriocarcinomas, things like that. And then I should have mentioned this earlier, but a structural vascular lesion. So AVM, cavernoma, these are the kinds of things that might look funny and require further workup.
And now let's go backwards in time and say this patient were a young patient with an intracerebral hemorrhage. How does a younger patient kind of present differently, or what kind of etiologies do you consider in a younger patient?
I still say hypertension should be high on the list in any patient, certainly if it's, again, in that deep perforator territory. And I think that hypertension has become more of an issue among younger people, and that's related to probably just the increasing waist size of America. But, of course, then there's sympathomimetic drugs of abuse, as well as decongestants. I've certainly seen patients that seem to have taken too many decongestants and presented with a hemorrhage, and diet aids as well. Structural lesions are more common in younger people, so I always have a higher index of suspicion immediately. And there have been cohorts of younger patients with ICH that have all gone to angiogram and reported structural lesions in up to half. And the other thing I think it's important to think about is that even a patient, if you do a drug screen, urine drug screen, and you find they did cocaine or methamphetamine or something that you think could be a plausible explanation for this event, I don't think that rules out an underlying structural lesion because it's going to unmask it.
How aggressive do you push for the conventional angiography in somebody who has a CTA or an MRA that doesn't really show an underlying vascular lesion?
So I think the non-invasive imaging is very important, as you said, and I think that's, for me, I do that in every patient, even if it's a classic hypertensive hemorrhage in a hypertensive patient. So then who then do I think needs an angiogram? I think younger patients, again, I'm always more likely to want to do it. If there's any suspicion on the CTA, a vascular lesion, I think you're buying yourself a conventional angiogram. And a non-hypertensive patient, that really is, for me, concerning. A patient comes in with a bleed and they're sitting on the floor with a blood pressure 130/80. Hypertension is not the problem here. Then another challenge is if you do an angiogram early, because you want to identify that lesion, if it's negative, do you have to repeat it later after the blood is resorbed? Because sometimes the hematoma compresses some of those structural lesions that you would otherwise be able to see on angio, and you can't in the acute setting. And if I have that high index of suspicion, I've definitely brought people back for recurrent conventional angiogram 4 to 8 weeks down the line. I'll start with the MRI and MRA first, but doing it one more time to be absolutely sure we don't miss something we can treat is important.
After you've obtained a history and you proceed with a physical exam, there's some features of the general medical exam that can be helpful in giving you some insight into the causes of the intracerebral hemorrhage. And I can't tell you the last time I really did a general medical examination on a patient, but
it was earlier today, right?
It was earlier today?
It must have been. You're on service, right?
Yeah. I looked at someone's skin briefly and listened for heart sounds.
Excellent.
There were heart sounds.
Good. I mean, you mentioned some of the important things. If you're worried about endocarditis, obviously getting their vital signs, seeing if they're febrile, looking for Osler's nodes, obviously listening for a murmur. A new murmur is obviously very concerning.
Endocarditis is not the only infectious cause of intracerebral hemorrhage, but it is one of the most concerning. Mastoiditis, otitis, or sinusitis can precipitate a sigmoid or transverse sinus thrombosis with associated ICH. So consider these infections in patients with fever and hemorrhage. HSV1 not uncommonly causes a necrotic unilateral or bilateral temporal lobe hemorrhage with significant edema. The related varicella zoster virus can also cause hemorrhage, but it accomplishes this via a vasculopathy with aneurysm formation and ICH in immunocompromised or immunocompetent patients. Finally, HIV is another consideration in young patients without an obvious cause of ICH, and this virus is associated with an increased risk of hemorrhage and stroke for reasons that remain unclear.
And then any of the symptoms of cancer, you should screen the patient for it. And looking for cachexia is important. And then looking at the skin, again, you might see purpura. You might see evidence of obvious coagulopathy.
Earlier you mentioned location can affect the way that you conceptualize causes of ICH.
Well, it does. It hugely does. Hypertensive bleeds are going to occur in those deep perforators, so the basal ganglia, the thalamus, the pons, the cerebellum. That's where those tiny perforating vessels are that are coming off of the large vessel that are experiencing those high pressures. And on MRI, of course, looking at the GRE or susceptibility weighted imaging for those microbleeds to see the pattern of that is really important. If you see microbleeds in those deep territories, you think, this is a patient who's been hypertensive for a while. And if it's an older patient and you see it in the lobar regions, you think, this is consistent with amyloid angiopathy. And not just in the lobar regions, but you also see superficial siderosis. You see staining of the meninges. And in fact, it's at least as specific for amyloid angiopathy as those microhemorrhages.
Other causes to consider in patients with lobar hemorrhage are metastatic and infectious foci, venous sinus thrombosis, and arteriovenous malformations in young patients. It is worth mentioning that AVMs carry the greatest risk of hemorrhage, about 2 to 3% annually, and usually affect patients in their third or fourth decade of life. The brain stem is a common site for hypertensive bleeds as well as cavernomas and developmental venous anomalies. Cavernomas, which may have a genetic component, carry a moderate risk of hemorrhage, between 0.5 and 1% per year. In contrast, developmental venous anomalies and capillary telangiectasias carry the lowest risk of ICH, less than 0.5% per year.
I forgot to mention, which I should have, was, what tips you off to being unusual is bleeding in other compartments. Mm-hmm. That is important. If it's a primary ICH due to hypertension, you don't typically see that. And instead, certainly in older patients, it would be very consistent with amyloid angiopathy. They tend to be more superficial, and I've seen patients present with subarachnoid and subdural and intraparenchymal hemorrhage, and it's amyloid angiopathy. Other structural vascular abnormalities also can certainly do that as well. Mm-hmm.
Vascular malformations associated with multi-compartmental hemorrhage include arteriovenous malformations and dural arteriovenous fistulas. We've talked at length about cerebral amyloid angiopathy already, but other things to consider would be hypertension in cases of intracerebral and intraventricular hemorrhage, cocaine or amphetamine abuse, coagulopathy or aneurysms of the anterior communicating or middle cerebral artery. But across the board, the most common reason for hemorrhage into multiple intracranial compartments is trauma.
So the only other thing I would say, cerebral vein thrombosis should be on everyone's mind with any patient they see with a hemorrhage, because it is managed so differently, and it is one of the most commonly litigated diagnoses for neurologists and radiologists. If they miss it, you can get in trouble. And obviously you're going to do a disservice to the patient. So you should always check the box in your mind when you look at a hemorrhage, could this be a vein thrombosis? So know the typical locations of where that would be, and don't be shy about asking for either a CTV or MRV to confirm that that's not the problem.
And the last thing I wanted to talk about was treatment. So not all causes of intracerebral hemorrhage are managed the same. We still target first and foremost the cause of the hemorrhage, and obviously try to normalize blood pressure and address all medical complications. But when can sometimes the treatment of the primary cause of the ICH be somewhat counterintuitive?
If it's a vein thrombosis and you're able to identify that, then the treatment should be anticoagulation. And if anticoagulation fails, if the patient declines radiographically or clinically, or is more abundant presentation and gravely ill, we will be aggressive and recommend an interventional procedure than a thrombectomy to try to get all the veins open, because that's the treatment. It's scary putting somebody with hemorrhage in their brain on a blood thinner, but really you got to get the venous clot out. And then certainly if it's a ischemic stroke with hemorrhagic conversion, and eventually getting on an antithrombotic in some time frame is very, very important.
Is there any other takeaway message you'd like to give our listeners before we close up? We didn't talk about prognosis.
No, we didn't. And we didn't talk about blood pressure reduction. What's a goal? I think that's sort of nuanced the data on that. It is controversial, but it is evidence-based. I think we really should be probably shooting for the 140 to 150 range as opposed to 180. I don't think that's the right answer based on the data that's out there.
Kind of along those lines, the incidence of just finding an ischemic stroke at the same time as a hemorrhagic stroke on an MRI. So you get an MRI for a patient to work them up for a hemorrhage, and it turns out they've got a punctate ischemic lesion somewhere else. Completely unrelated, asymptomatic for whatever reason.
Yeah.
And maybe because of blood pressure reduction, maybe because it's associated with the mechanism of the stroke, if there's a hypercoagulable state or whatever else going on. And that risk increases with age, and that risk increases with cerebral amyloid angiopathy too.
Yeah, that's a great question. That's a really interesting question. There was a paper in Neurology and an editorial by Kevin Schath, who's a neurointensivist at Yale. He's a terrific guy. His title of his editorial was Silent but Deadly, which I thought was funny. But what he was saying was that these small ischemic strokes that are often found, up to like 30% of patients will have them on MRI, these little ischemic lesions. After an ICH, what is the implication of it? We don't really know, but it seems like patients maybe do a little bit worse. You made an excellent point that could be related to amyloid angiopathy, and we know that if we just do routine MRIs on these patients to look for progression of microbleeds or macrobleeds, we will pick up infarcts in 10 to 15% of patients. That was published by Steve Greenberg. They've done amazing. He's really just the leader in this. And I think the answer is that this is a small vessel vasculopathy that's leading to both ischemia and hemorrhage. But boy, they're treating somebody with an antithrombotic with amyloid angiopathy is always hair-raising.
Well, I think that's been very helpful. I really appreciate your time. Thanks so much for being on the show today, Dr. Messe.
Always a pleasure to be with you.
Thanks for listening to BrainWaves today. If you like what you just heard, you can find more related material on the web at brainwaves.me or find us on Twitter at brainwavesaudio. Feel free to contact us at bweditorialboard@gmail.com.
Be sure to check out our iTunes archive for older episodes.
This episode was produced by Jim Siegler. Music by Steve Combs. I'm Erica Mejia. Join us next time for another edition of BrainWaves.